Osteoarthritis is the most common type of arthritis. It's generally known as normal wear and tear of a joint. The exact etiology of osteoarthritis is really unknown at this point. There are a lot of multifactorial issues that go into it. Age determines the amount of arthritis that you can have. Previous injury can cause it. Somebody's weight is an issue. Obesity is a big or large contributor to osteoarthritis. So a lot of things kind of make up the pathophysiology of osteoarthritis, but the exact reason that we get it is really unknown at this point. The symptoms that you get from osteoarthritis can vary between stiffness in a joint, pain or swelling of a joint, and everybody experiences these symptoms differently. They can be mild, moderate, or severe. There's really no way of knowing how much pain you're going to have dependent on the amount of arthritis that you have, and some people can tolerate the arthritis a lot better than others, but typically pain, swelling, and stiffness of joints are the main symptoms. Diagnosis of osteoarthritis is mainly through physical examination by a physician or x-rays if necessary or if are thought to be warranted. Sometimes the examination, you're looking at the range of motion of a joint, or if there's a deformity in the joint or nodules that are felt from the arthritis, because there's sometimes bone spurs that can actually be palpated through the skin. And then typically after that, an x-ray will be obtained to look at how much damage there has been done to the joint. Typically, further diagnostic imaging, like advanced imaging with MRI and CAT scan, are rarely, if ever, necessary. Osteoarthritis is the most common arthritis in the country, and there are 31 million people that have been diagnosed by a physician to have some sort of arthritis in this country. That number is actually expected to go up to about 78 million by the year 2040. As I said previously, the exact etiology of osteoarthritis is unknown. We do know that age plays a role. If you've had some sort of previous trauma, if you're in a car accident, or if had a fracture that's around a joint, that can affect the biomechanics of the joint and lead to some earlier arthritis in that joint. Weight, the heavier somebody is, the more pressure there is across that joint. We do know that women are more affected than men. But typically it's just the normal wear and tear. Heredity does play a role. You can also have birth defects. If you have a hip dysplasia as a child where the cup of the hip socket itself doesn't form correctly, that can lead to osteoarthritis of that joint later down the road. Traditionally, over-the-counter anti-inflammatories and Tylenol or acetaminophen are the first-line treatment for pain that is experienced from osteoarthritis. And typically, by the time somebody comes and sees me in the office, they've certainly tried those things. And there are also a lot of people that can't use any type of NSAIDs, such as ibuprofen or Aleve or naproxen, because of whether it be heart issues or stomach issues. Ice, heat, anything that's going to kind of try to decrease the inflammation of a joint can be helpful. Getting off of the joint, so if you're on your feet all day and your knees are hurting because of arthritis, and just sitting and getting some ice on your knees may be helpful. But there are certain circumstances or the severity of the arthritis where that doesn't help, and more aggressive treatment is necessary. There's no technical cure for osteoarthritis. There's really no way of stopping it, reversing it. There is a permanent treatment for it, however, and that would be a total knee replacement. If you have an afflicted joint with severe arthritis, there's really nothing that can be done to cure it. However, the definitive treatment would be to replace the joint. Everything other than a replacement is technically just a Band-Aid to see if you can postpone a total knee replacement or delay that for as long as possible to certain people's social needs, or they may have a vacation they need to go on, or they just need to retire. So there are a lot of treatments that we can do, but in actually curing the disease, there is not one. So cortisone is a treatment that we use in one of the mainstays of treatment in my practice. I do a lot of injections, whether it be in the knees or the shoulders. Hip injections are a little bit more difficult and typically need to be done with either an x-ray machine or an ultrasound machine to make sure it's actually in the joint. But long-term treatment of that can really cause detrimental effects on the remaining cartilage, the remaining joint. Long-term, it can also affect your own hormones. We have, our body produces a steroid itself. It's produced actually in the adrenal gland, which is above the kidneys, and your body will sense how much cortisone or cortisol is in your bloodstream, and it will release the corresponding amount depending on how much you might need. Now, if you get too much cortisone too quickly together or chronically for long term, it can actually make it so your body quits producing it because it doesn't feel like it needs it, and then the adrenal gland that produces that cortisol will actually quit functioning. Joint replacement surgery is an extremely difficult decision to make when it's time, and everybody's different in terms of how much pain they can tolerate and how much they can have, and each person has to make their own decision in terms of when they are ready. In terms of when is it time, I usually ask people two questions. Does it hurt you every day? Does it prevent you from doing things that you enjoy? And if somebody says those two things are true, then at that point we really start delving into whether or not it's a knee replacement or hip replacement would be necessary or appropriate for them. The goal of surgeons here over the past several years is to really try to expedite the recovery of surgery. We've gone through this evolution of different types of ways of doing the surgery, minimally invasive surgery versus the traditional more invasive surgery, and really we've kind of really honed in on perioperative pain control, controlling the pain before surgery, controlling the pain after surgery, and really encouraging people to get up and move in order to expedite their recovery as quickly as possible. Now, everybody's different in terms of recovery. I have some people that have a knee replacement that walk in 2 weeks, doing very well with hardly any pain, and then some people that take longer, 6 weeks to 3 months. But typically, the majority of people do very well, and also depends on your health going into the surgery. It depends on what your expectations are afterwards in terms of what you feel is normal activity. One thing we know about knee replacements is that they do very well if they're put in well. And so the goal of, I think, all orthopedic surgeons is to do a very good job, no matter what type of implant they use, but to do a very good job of putting the knee in appropriate alignment. Because one thing we know, if the replacement's put in good, normal alignment, then it's going to last longer and patients will do better. I personally use a piece of technology called Ortholine, which actually uses GPS navigation. It's a handheld computer, essentially, that gives me the patient's normal mechanical axis of their femur, as well as or the thigh bone, as well as the tibia or the shin bone, in order to put this in as perfect alignment as possible. And what I like about this equipment is that it actually gives me real-time feedback, and so you can actually manipulate it and move it and change the angles based on what you're seeing in real time. Currently, you do not need a referral to see us in the office for an appointment, and as far as I know, we take all insurances at this time.